First step fixing the problem is admitting you have one. So I like to put up this slide just to give us a scope of a sense of the scope of the problem. Cardiogenic shock is something that we treated and proceeding in the background. So cardiogenic shock, particularly cardiogenic shock related, unrelated to an acute myocardial infarction. I think just a basic principle is patients can often go into cardiogenic shock with a STEMI or an NSTEMI. That is this bottom yellow line down here. But the biggest category that's growing is this non-AMA shock. This is the decompensated heart failure patient who goes from NYHA class 3 ambulatory maybe congestive to entering into shock. That is growing precipitously. And one of, I think, the great shames of it's still yeah, I think that plug it in the PowerPoint. There we go. Okay. So I think one of the great shames of cardiology is since in the past almost 2 decades, since 2008, we really have not made a dent in terms of cardiac shock mortality. We're about 35 to 45% of patients in the hospital with cardiac shock will die of cardiac shock. So we have to do better. And that's in spite of an explosion of our fancy toys we can use to manage our pumps, our balloon pumps, our propellers, our tandem parts, our back pumps. We have those tools, and yet the mortality remains 35 to 40%. And we're using a lot more pumps nowadays, particularly in the pre-transplant space, because that is currently the way that the allocation system for heart transplants is set up. So our sickest of the sick patients awaiting heart transplant, there's just been a massive growth of use of temporary mechanical support. Sorry, each time there's a message.
So, sorry.
It's okay. How do we move the needle on this? So I think we have to be able to recognize shock at an early point in time. We need to think about how to use invasive hemodynamics to guide shock. Have a phenotype. And any patient we're going to use temporary mechanical circulatory support, I like to have an exit strategy. Talk about what that is. Either just to click on this, maybe, or direct.
Oh, I can click on.
Yeah, I'll just say next slide.
Yes.
So let me start with a case. This is a recent case, 24-year-old with a non-ischemic cardiomyopathy. We have him on a medium dose of guideline-directed medical therapy. Our beta blockers are angiotensin receptor blockers. Came in with sort of non-specific symptoms, nausea, low appetite, and blood pressure not too bad. Actually pretty typical for our heart failure patients, 100/60. Next slide. And this was a change in symptoms. He's not normally nauseous. So we said, let's go get a right heart cath. Early identification. This is what we saw. His right atrial pressure was 23. His wedge pressure was 44. These are astronomically high. His pulmonary artery saturation was 20%, which gives him a cardiogenic of 0.7. He's profoundly sick. His systemic vascular systems are pretty elevated. So that normal blood pressure and setting low output, he's pretty clamped down. It's one of these young patients that can vasoconstrict. So we activated what we call a shock team. I'll show you a slide on this in a second. And what we debated was, does this low cardiac index right now indicate use of a pump, Hello, or balloon pump, or could we try inotrops? He was pretty vasoconstricted. So we went with inotrops. We started the betamine, profound response. So began peeing. He hadn't been peeing. He started to feel better day after day after day. His lactate, which was a little bit elevated, came down. We diuresed him with stabilized. Unfortunately, we were unable to wean him off the betamine after several attempts. And so right now he's maintained on the betamine, and we're pursuing an LVAD evaluation for him and think we can get there. We can't go quite to transplant because it's an elevated body mass index. Next slide. And so when I think about cardiogenic shock, there's a couple of components here that are just essential. Everyone here that's taking care of a patient is standing. We know that there's a durable balloon time of 90 minutes. In shock, the moment the patient gets to the hospital, you want to have a high index of suspicion for low output symptoms. It's nausea, vomiting, lightheadedness. because so much of the physiology of shock is progressing in that first couple hours in the hospital. We call this the golden hour of shock. Next slide. And the way we manage these at the University of Utah is we have what's called a shock team. So we page out if there's a concern for shock, and a heart failure cardiologist such as myself, a cardiac surgeon such as Matt Goodwin, an interventional cardiologist, one of the intensivists in the ICU 24/7, gets the page. It might come from the emergency room, it might come from the CVICU or the operating room. If it's a STEMI patient in shock, they'll go down a STEMI pathway with the cath lab. We'll also most often have a discussion, but bring the non-STEMI patients also to the cath lab so that we can get invasive hemodynamics. Next slide. And what we saw is before this program was rolled out, about 2015 to after, we had a dramatic improvement just by getting these providers all to talk together about a patient. The survival in this cohort went up by about 10%, hitting now 75% survival. So much better than the 35 to 40% we're seeing nationwide. Next slide. But you have to ask, what it's not, talking about a patient doesn't make them better. So what is it that's actually happening? So this data comes out of the Critical Care Trials Network, not just the University of Utah, but multiple CCUs and CVICUs around the country. And there are a couple differences that happen when you activate a shock team and discuss these patients. So there's more use, this dark blue on the left is the shock team. There's more use of a pulmonary artery catheter, like a Swan-Ganz catheter. There's actually less overall use of mechanical support, but when it's used, it's more typically advanced mechanical support. So not just a balloon pump, but Impellas or ECMOs or temporary or durable LVADs that can be surgically implanted. And the mortality is improved nationwide, not just at our hospital. Next slide. And that's despite there being a sicker cohort. So the patients that are activated for the shock team, they have a lower cardiac index. They have a higher wedge pressure, a lower RV function defined by the pulmonary artery pulsatility index. So these are sicker patients that are doing better. Next slide. And this is a breakdown of which types of mechanical support are being used. So a little bit less use of balloon pump, a little bit more use of Impella, more use of tandem arc, and about comparable use of ECMO or some of the temporary surgical beds. Next slide. And so maybe the shock team approach tells us a little bit more defined which pumps are going to better serve this patient. Have that discussion. Another aspect is that we're using more pulmonary artery catheters. There was a debate going back a little over a decade. So there was a trial called the ESCAPE trial that looked at randomized use of the catheter versus standard of care clinical assessment. Next slide. And there was no survival method. So fortunately, this turned the field away from the use of PA catheters for heart failure. Next slide. And going back to an editorial that came after this that really was pervasive in the field, based on ESCAPE, there's no indication for the routine use of PA catheter. We got away from this. There was a good decade where we had stopped using these for patients in shock, where there's a problem. Next slide. Which is that acute heart failure is not shock. Acute heart failure is on the spectrum towards cardiogenic shock, but shock is a distinct entity. The warm and wet heart failure patient might just need diuresis. They don't need a PA catheter. But a patient whose lactate's elevated, who's not peeing, who's hypotensive, who's underperfused, is a different patient. And we actually think that there is utility for a PA catheter in this demographic. Next slide. And just, to define that, so in ESCAPE, there was high dose of Lasix was an inclusion criteria. They were tolerating these. Many of our patients that are in shock, they're no longer tolerating these drugs. It's a different group. They were just congested, and they excluded people who were already on or millimole. Many of the patients that will start in the hospital, they might be started on either before we received them or in the emergency room because we just were clinically suspicious for shock. They would have been excluded from this trial. They have AKI, evidence of end organ injury. So when you've got a sicker patient, I really think that there is a justification for more use of PA catheters we as a nation are currently using. Next slide. And when you do that, so the observational data is that PA catheters lead to improved survival. Obviously, the PA catheter itself is an improving survival, but it allows more tailored application of the therapies that we have, inotropes, temporary mechanical support. Next slide. Observational data is not perfect, so we do want to answer this with the gold standard of evidence. So there is a trial that we're participating in called the PAX trial that is a randomization in shock, not escape that looked at heart failure, but in shock for the use of a P catheter versus no P catheter. I do worry whether this too will have problems with enrollment, because most of the time, many of these centers, we probably don't have echo problems. The sickest patients, we can just go without a P catheter. And so we're going to see where this trial goes. But for now, we're a center that we aggressively use the P catheter. I'll be kind of interested to talk later about what we do here for our shock patients. Next slide. Once we've got the P catheter in place, looking at the clinical details, we want to think about what type of shock is in front of us. And this can come in many different flavors. So this is what we call phenotypic shock. The severity of the shock. We're going to talk about the SCAI classification system that hopefully at the end of this talk we're all familiar with. Defining the anatomy. So not all shock is just left ventricular shock. It might be biventricular shock. It might have a greater degree of pulmonary arterial hypertension, precapillary PAH, that requires different management strategy. The etiology of the shock, we don't yet know what to do with, because most of the data around management of shock comes after a patient's come in with an acute myocardial infarction. We extrapolate a lot in the non-heart space. So from a research perspective, we're studying that in great detail. But it's useful to understand a little bit just the prognosis that comes from these different etiologies. And then the trajectory. So all shock patients have a trajectory. That trajectory might be recovered. That would be wonderful. Not every patient can recover. So we have transplant, we have LVAD. Sometimes the patients are unable to wean off of support, and we need to have to-the-minute palliative care discussions about goals of care and the fact that patients die. That's not uncommon. Next slide. SCAI staging is a useful metric that I think is easy to apply to the bedside, easy to remember. Just like in heart failure, we have the New York Heart Association, NYHA class 1 through 4. In shock, when a patient's with me at bedside, I make my residents do some rounds. I want them to apply the SCAI stage. This is a degree of how severe is their shock. SCAI is the Society for Cardiographic and Angiographic Interventions that our interventionalists are part of. And it's A through E, A, B, C, D. So A is your at-risk patient. This is a patient who is not in shock. They're hypotensive. They're not hypoperfusing. Their organs are working. But they have maybe heart failure, or they have. They're at risk for developing. Stage B is a patient who is either hypotensive or hypoperfusing, but normotensive, and not really requiring much in the way of inotropes or temporary support. Stage C is your classic shock. These are patients that might need a low to moderate dose of inotrope alone, and they succeed with that. Stage D are patients who, on that dose of inotropes, are continuing to slide. Their lactate keeps going up. They continue to have poor perfusion to the kidneys. They're not peeing. And they may need either high-dose dual inotropes or temporary mechanical support, such as the Impella. And stage E is an extremis. These are patients who, despite aggressive therapies, continue to decline. They're at high risk for mortality. That you can see here, almost 70% mortality in the SCAI E patient. We've got to be able to do something for that patient that's different than just sitting there and watching. We know this patient's about to die. We have to be aggressive with therapies. If they're going to be a transplant candidate, if they're going to be a LVAD candidate. So who comes to this category? Patients on VA ECMO, patients who have had a cardiac arrest. These patients are at extremely high risk of death. We have to be very careful with our management. And SCAI stage is not static. So if you look over the hospital stage, this comes out of the trials network. Patients that come in B through E will progress. And actually, it's the patient whose SCAI stage worsens throughout the hospital stay who's at a greater risk of mortality. You look at SCAI E, 53% mortality. That's as sick as they get. But if you look at patients who come in as a B and progress to each subsequent stage up to E, they go up to a 75%. That's about comparable. Anybody in the hospital that progresses to an E, essentially fails temporary support or has a cardiac arrest, there's such a high risk of death in this group. So trajectory matters. Next slide. And why this trajectory matters, this is my favorite slide. It comes into every talk that I give on shock. Shock is not just a hemodynamic state. The hemodynamics are altered. The patient has an MI, they have decompensated heart failure. Something happens that triggers a low output body. The problem is the body then starts to lose compensatory vasoconstriction. What do I mean by that? Patients with heart failure, their systemic vascular resistance can maintain blood pressure. Patients in shock lose that because the body sends out an inflammatory response. They have a surge response that, in medical school, I remember being taught that cardiogenic shock was a low output, high SVR state. It's not the patients that are in our CVICU. Patients in our CVICU have begun to vasodilate, and they are unable to maintain blood pressure and perfusion because of this sort of death spiral. The problem is, even though I use this slide every time I give a talk, we don't know all the elements of this death spiral. We don't know how to intervene and stop it, other than early recognition of shock before we enter into it, and maximal stabilization with perfusion targets once they've activated this death spiral. Next slide. So I want to talk a little bit about who requires temporary mechanical support. I think we're going to be good on time. Next slide. One of the paradoxes in the field of cardiac shock is that every time we run a trial to look at the use of a pump in shock, the IABP Shock 2 trial, so the Holger Thiel out of Germany runs several of these trials, keeps really challenging our use of these pumps. We've never been able to show in a randomized trial that these pumps do anything to improve 30-day survival or survival within 30 days. So this is true in the IABP Shock 2 trial. Next slide. We looked at Impella, so this is the Impella 2.5 in the ICER trial, air to balloon pump, so sort of marching out. There was no survival benefit here. Next slide. But there are some limitations to these trials, some very significant limitations to these trials. Number one is, I just wrote a list of all the trials that have been done in shock. I want you to notice a pattern here of who got included. STEMI, AMI, STEMI, AMI, right? So we've never studied in a randomized setting the use of these pumps in non-AMI shock, which that first slide is that growing population. So we have a whole knowledge that we've extrapolated some data from AMI shock. It's not the same entity. Next slide. And why is that? There's a difference in terms of what the body sees from AMI shock that happens acutely. Somebody's normal walking around, living their day. They came out here to ski. And then they go into shock. The body responds differently than the patient who slowly declines from heart failure into shock. There's different pathophysiology that we need to better define, but we suspect is there. Why do we suspect this? Next slide. Is because they have different outcomes in spite of the same management strategy. AMI shock actually typically has a higher mortality, 42% compared to 25% in this study out of the cardiogenic shock working group. Next slide. And so one of the limitations is everything we know from a randomized setting about temporary mechanical support use of cardiac shock comes from AMI. That's not what all the shock that we're seeing is. Second is, if you think about who actually makes it into these trials, if you've got a patient, you put a stent in for a STEMI and their blood pressure is 60/40, probably not enrolling that patient in IVP shock 2. You're putting a pump. We don't have equipoise for the sickest of the sick. So it's probably the case that randomized trials are always going to be limited in the cardiac shock space because you can't be there as a provider and not want to do something that just makes sense. Even though you were going to be scientific, you would enroll them. They're not getting the trial. There's not every patient's the same. Not every time in shock is the same. So we really didn't target the right time, the right patient, the right pump. These trials are small. And really, sort of philosophically, the endpoints of these trials are not the right endpoints. Pumps don't improve survival. They don't cure the disease. They are a bridge to something, a bridge to recovery, a bridge to transplant, a bridge to LVAD. You have to know that the patient you're putting that pump in has some sort of strategy, an exit strategy, that's going to allow you to have some other endpoint. The endpoint's not survival in and of itself if you're going to design a trial. Next slide. So when it comes down to the hemodynamics that I think are most favorable for the use of temporary support, this is from a review article we're writing now that I just put here. So if you put on one axis how vasodilated a patient is, so a patient with a really low SVR, or a vasoconstricted patient, really high blood pressure, right? And on the other axis, you put how challenged is their perfusion. You can define that by cardiac output or their lactate or their urine output, their liver enzymes, symptoms. most of the patients in that Sky C shot, we're going to use an inodilator like a milrinone or a meter because we can dilate the blood vessels. The heart likes that, drop an afterload, and we can squeeze the heart and they're going to succeed with that. Some patients are so vasoconstricted, their SPR is 3,000. We might just use something like a nitro, a vasodilator patient. We don't even need a nitro. That's the healthiest patient on unit, the high SPR patient. Sometimes patients are hypertensive, not uncommon. We're unable to use milrinone or dobutamine without adding on a vasopressor as well, like norepinephrine or Invasive itself. And there are some patients that don't need inotropy, right? They just need a vasoconstrictor because they have enough output, but they're a heart failure patient. Maybe they're septic or maybe they have some surge response, right? So if you think about the patient who needs temporary support, it's when I am unable to add on a vasoconstricting agent without dropping the perfusion. Their MAP is 50, and I need to improve perfusion of the kidneys, but I can't. Or it's the patient who is so vasodilated that I can't add something like milrinone or dobutamine without dropping their blood pressure. It's that balance between blood pressure and perfusion where there's no way to win the game with medications alone. That's the patient who I think is certainly deserving from a hemodynamic standpoint of the use of temporary support, temporary mechanical support. Next slide. When you use these pumps, you have to know ahead of time, before you put the pump in, how's the right ventricle doing? Right, that's really critical because patients with biventricular failure are at much higher risk of death. And supporting the left ventricle alone might help the RV. We offload the LV, which offloads the lungs, offload the RV. It might often not be enough. How do we define the right ventricular involvement? A TTE, a bedside ultrasound, if you're doing this quickly, or a formal echo can help. I also have 3 parameters that you guys should remember for assessing the right ventricle once you've got that PA catheter replaced. The right atrial pressure, so CVP or heart rate pressure, if it's greater than 10, we might be in some trouble. Maybe they're so congested on the left side, however, that it's brought up the right atrial pressure. Usually it goes up about a 2 to 1. If the wedge is 20, the right atrial pressure might be 10. If the wedge is 30, the right atrial pressure might be elevated to 15, but it's about 2 to 1. So if you look at that ratio between the LV and the RV, the wedge to right atrial pressure, as the CVP starts to go closer and closer to the wedge, closer to 1 to 1, the RV is in a bit of trouble, right? So a wedge of 20 and a CVP of 20, that's biventricular failure. The only exception can be pulmonary hypertension, can also make the CVP higher. So there's a very useful, quick, easy to calculate index called the PAPI, the pulmonary artery pulsatility index. I look at this for every patient. And I'll tell you how to calculate it in a second if you don't know. It's less than 2 is mild and less than 1 is severe. So we think about this a lot for LVAD patients. Is LVAD enough alone going to be enough, right? Is this, as a balloon pump alone, going to be enough? Next slide. If you want to learn how to calculate it, if you have the pulmonary artery pressures, the PA systolic and the diastolic, as the CVP goes up, that system should be more pulsatile. So that's the formula up there. You know, I gave an example. The RA of 15 and a wedge of 20, that would equal a PAPI of 1, which is severe RV failure. Okay, so you got these metrics. We're going to try to define RV failure. What do we do if we have concurrent RV failure? We can't just put in a left side of the column. Next slide. We've got a couple options. I'd say the one we're using most commonly, there's several advantages. Protect Duo. There's inflow port in the atria, and it then has outflow into the pulmonary artery past the declining valve. We are very familiar with it. We like this pump a lot. There are other options. Next slide. The RP Impella is another option. Not as great for the IJ insertion, and so the femoral access, and again, it's a good pump for the RV side. Next slide. You can't just put in the pump, you have to choose a flow. So how do we choose flow? We call this flow dosing. Another review article pulled this from. So look at your targets for blood pressure, look at your targets for perfusion, your lactate, et cetera. This is very simple. If you're not meeting your targets, go up on the flow. But there's a problem, which is that if you increase the flow too much, you can get some flow-mediated harm from the pumps itself. So the higher the flow, RPMs in most devices, the higher the shear forces, you're going to have more hemolysis. If I've got a small pump, if I've got an Impella CP and I'm on day 3 of it, and I'm running at P9, the highest pump flow, I'm a little bit worried about hemolysis and the damage that may do to the kidneys or other organs of the body, or just the anemia. So I might want, if they're meeting their perfusion targets, not just sit them at P9 the whole time, bring them down. And so do flow dosing where I want the least amount of flow necessary to maintain my blood pressure, my perfusion. And no ECMO, right, is the one you have to be, is the one type of pump you have to be worried will increase your LV afterload. So I think of ECMO is very good for the body. I don't think of it as good for the heart rate. It's actually loading the heart. And so you may need a concurrent loading strategy with a configuration that also includes a impella or a balloon pump or just inotropes. Next slide. How we choose an inotrope, and I'll try to wrap up in a couple minutes for questions. We have a few options. So dobutamine and milrinone are workhorses. Is there any difference between the two? That was a question. Should we be using one over the other? Next slide. And so there was a trial called the Do-Re-Mi trial, which was dobutamine versus milrinone, and there was no difference. So this actually was kind of landmark. Everybody had their preferences, their pocket inotrope. There's no survival difference. There are a few practical differences, however, that I think about. Next slide. And so I do still say, fine, I can choose whichever one I want. However, if I need something on quickly, dobutamine has a shorter half-life, so I'd like it for quick on, quick off. I'd probably use dobutamine 9-to-1 when we're in the hospital in the acutely compensated setting, because I can see the effects and the titratability within an hour or two and not wait 4 to 8 hours like you do. I do try to avoid it if somebody's already got a tachyarrhythmia, an AFib or a flood or something like that. Milrinone is going to cause more vasodilation. Sometimes I want that in the high SVR state. You have to avoid it in AKI, acute kidney injury, because it's renally cleared. And so your patient comes in day 2 of milrinone, now their SVR is 600, they're hypotensive. It may not be sepsis, it might be the milrinone is accumulated in the setting of the AKI. It is slightly better in pulmonary hypertension patients. It has more pulmonary vasodilatory effects. And it is, if you've got a patient that their PICC line keeps falling out in the outpatient, probably a better fit because the half-life is longer. So if it falls out, they've got several hours at home to come back into the ED and reinsert that PICC line. So it may be better for an outpatient long-term bridge to transplant or palliative inotrope situation. Next slide. I said this earlier, but many patients with inotropes, it is not counterintuitive to have to use a vasopressor at the same time. My trainees are always hesitant to start leaving or invasive and heart rate patient. Oh my goodness, I'm going to increase the afterload. But I don't care what the cardiac output is. I care that the body and the organs and cells are receiving oxygenated blood flow, and they need a perfusion pressure with MAP in order to drive blood into the kidney or the capillaries. So I need a MAP, and if I have to sacrifice a little bit of cardiac output in order to generate MAP, that trade-off is totally valid to do. Next slide. You have to have an exit strategy. So I said this a few times, but whenever I'm putting any pump in, AMI or decompensated heart failure shock, I'm thinking already before I put it in, what am I using this for? It is true that sometimes I'm just meeting a patient I don't know yet, so I might buy time. So maybe it's a patient who's 40, and I'm assuming that they're going to be a candidate for something, or I'm going to try to recover them. I'm probably not doing that in a 90-year-old just to keep them alive to make have palliative discussion, right? So you don't want to put it in if you have an exit strategy. Somebody with a terminal illness, terminal cancer, some reason that they're not going to be a candidate for you. Don't use these pumps. It just creates a messy situation. We do it, but it's not great. So who do I think is going to be recoverable? It's a young patient. It's a quick on shock can sometimes be quick off, right? Particularly if they've never seen guideline-directed medical therapy, if they have heart failure. There's a lot I can do there. So that's a patient I want to aim for recovery. Certain etiologies of shock are more recoverable, tachyarrhythmia-induced, alcohol-induced, pericardial cardiomyopathy. There's etiologies that I think are going to be recoverable. Otherwise, after a few days, if I'm not making much progress, I'm already thinking, can I go towards all that? A little bit beyond what I have time for to talk about candidacy for those, but if you've got a pump in place, it should be at least the back of your mind. Does this patient need an exit strategy that's going to include a higher level of care? Next slide. I put this all together with a mnemonic called the ROSE mnemonic. So how do we treat shock? So we have to recognize shock, we have to optimize shock, we have to stabilize shock, and we have to have an exit strategy. So number one is in a patient with the correct etiology, they have heart failure or they have an AMI, think about shock for every patient. Because if you don't think about it, you'll miss it. We miss it, and I'm sure everybody at every center misses it, but if you can intervene early in shock, you can avoid the death spiral of shock where we get to the surge response of being that our pumps don't work, inotropes don't work. So recognize it early, optimize them, really get your targets for blood pressure and perfusion up there. Once they're there, make sure you can stay stable, try to wean off whatever support you have, and then have an exit strategy, whether it's de-escalation, which would be the greatest, the best scenario, or an exit strategy. Next slide. So to conclude, we have a high cardiac shock mortality. We need better randomized trials. I'm not holding my breath because of this problem with equipoise. We're going to enroll, right? So we have to have other data. Hemodynamics are critical. Shock teams, I do believe, improve survival. Up for debate. Elements of them are the essential elements that are going to improve survival. And recognize, optimize, stabilize, and have an exit strategy. If I have 1 more minute, which I do, next slide. What's next in shock? So we're not just trying to treat shock. We are trying to better understand it. So there's a couple observational studies out there in the world of cardiac shock working group. AHA just past year has been enrolling patients. We're already up to 1,000 patients in the country with shock, and the Critical Care Cardiology Trials Network. Out of the University of Utah, we have a multi-site study we launched about a year ago called Vanquish Shock. The goal here is we're not just getting EMR-based data. We're trying to actually collect blood on patients and collect biomarkers because we think that there's something happening underneath the hood related to the death spiral that we want to better define. So we have new points of intervention, new drugs that are going to work, and sort of the next 5 to 10 years worth of therapies that we're not going to get just by the same variables we keep collecting. So we're doing that at Utah, and Inova, and Toronto, and Goodwin. Next slide. And out of this is a couple grants that I'm working on. So we're trying to understand whether that vasodilation is actually a loss of the venous intensity system seen in septic shock. So I have a grant from ISOG working on that right now, and it's an exciting time. But stay tuned on whether we've got some new therapies down the line for cardiac shock. And that should be everything. So I think what we did here, we built in time for questions, about 10 to 15 minutes of questions. So happy to build anything. Yes.
So
you want to hear?
no, okay. I can probably talk loud. Yeah.
You're loud.
So you mentioned that you're seeing more and more cardiogenic shock, but not in the setting of AMI. So what is causing all these increases of cardiogenic shock?
So I think our patients are getting sicker. So I think it is slightly disingenuous to say, oh, we haven't made a dent in cardiac shock mortality. I actually think that our guideline-directed medical therapy works, right? Our beta blockers, our RNAs, our SGLT2 inhibitors we have now. So patients are living longer with heart failure. And so now we've got a growing population who we have kept alive, except, that heart failure is still a relentless progressive disease in spite of GDP. Although they're older, now they have a little bit more kidney failure, a little bit extra age. They're coming to us sicker, but heart failure still comes. There's nothing that we have other than a transplant that stops the process of heart failure. And so that's a growing population. Our population size is growing. On the flip side, I think we've actually made a lot of progress in the AMI space in terms of avoiding shock. The systems of care are built around delivering AMI care, STEMI care, during balloon time. So I think we're doing a better job, even though the population is growing, we're doing a better job in AMI. I think the heart failure population is growing without really an exit strategy. So that population is growing at a bigger rate.
Thank you.
Thank you.
The patients that come in and stage 4 heart failure, that come into the office to routine visit, what do you do into to try to differentiate? And when they come in, a lot of hospitals support. So what do you do into to give you that kind of sixth sense that, I'm looking at something a lot different from what's sick than I'm going to do?
Yeah. So one realization I had somewhere along my career is that a lot of the patients we have in the clinic in heart failure are in shock. I call it ambulatory shock. They're not in the hospital in shock, but they're sitting there in shock. And I try to listen to the degree of symptoms, the trajectory of the symptoms, and clue into one other important detail is, are there symptoms driving me to back off on their GDMT? When I have to have a patient who for years was on full dose Entresto, full dose carvedilol, and all of a sudden I'm backing off on it, what's happening? That patient's heart failure is beginning to progress, and they're beginning to enter that vasodilatory state too. Their blood pressures are dropping. It's not low blood pressure simply because their output's dropping. They're literally vasodilated. They're losing that element of compensatory vasoconstriction to maintain blood pressure. So that patient's getting sicker. What do I do practically? It depends on the patient. So I'll typically try to get a right heart cath early and on. We send patients all day, every day for right heart caths because I need to look under the hood a little bit and understand hemodynamics. And I'm already beginning to have the conversations. If they're NYHA4, if they've ever touched an inotrope, even if for a day in the hospital, if I'm backing off on medications, if they have progressive organ dysfunction that clues me into the systemic pathophysiology of heart failure, I'm thinking advanced therapy. I'm thinking they need LVAD workup, they need transplant workup, or if they're 80, or 85, or something that we need to start having palliative conversations to plan for what's inevitable, which is that they're dying from their heart.
Is there a measurement of that loss of faith other than a heart cath?
So that's a brilliant question. I want there to be one. I worked with our vascular biology research group to ask that question. Say, is there some sort of tonometer I can put on the leg or ankle? It doesn't exist right now. And so we go to the record. Yeah, but we're looking at drivers of that. We understand the mechanism. We don't understand why that process happens, but it seems to happen at the end stages of heart failure.
Dr. Hanff, there's a question in the chat about whether there are COVID patients in this study, and if so, what are you seeing with them?
Yeah, I probably put it as I put up one of the several studies I listed. So I'm not sure 100% which study, if they want to clarify. Yeah, so the question was, are there COVID patients in the study? And how does that impact, I think, the results of it, maybe? So I'm guessing. Which study that I mentioned? I'll speak to just COVID in general. So we have a high and growing volume of COVID myocarditis. It is not often resulting in heart failure, but it occasionally does. We've had some vaccine-associated myocarditis that has resulted in heart failure. And we try to put these people on high doses of GDMT. I'd say that there's one challenge with this is a lot of orthostatic hypotension that comes along with COVID, long COVID as well. So if they have the long COVID, we're struggling a little bit with GDMT, but their heart failure tends not to be that profound. So we can get low doses of it on and stabilize them. But, in some patients, they've had to go on for a heart transplant because of COVID. Temporally, they had COVID and now they have new heart failure. It's possible some of these patients had vulnerability before. They had coronary artery disease or they had previous, we've had viral myocarditis for years. It's just that we had a lot more of a virus going on, which was COVID. It's not a new entity, other than the degree of maybe autonomic dysfunction seems to come along with it. If they clarified what study,
They said they don't know the name.
Okay, sorry.
It's fine.
Yeah. Yeah, so ECLS shock, UCB, ECLS in shock post AMI. We are very conscious that ECLS is not a good option for every patient that comes in with shock and pulselessness. So I guess the broader question that we've been working on for years, even before ECLS came out, ECLS shock, was just trying to define who are the patients that we ought to crash onto VA ECMO. So we've got a pretty robust protocol. We do push the envelope sometimes in patients that exceed the protocol by age or something because we've got such a powerful technology. But almost every time we do an M&M afterwards, we have a root cause analysis. It's when we exceeded the protocol that we find we keep fighting ourselves, wishing we had just done what we set out to do when we made the protocol, right? So ECLS is a great technology, but you really ought not to be using it in extreme cases and extreme age and other comorbidities that we have right now. What do you guys, did it impact for you guys? And Matt is our cardiac surgeon here too. You could even jump in if you want on the ECLS program, putting in a lot of that. We'll get into this time in a second.
Part of the source of the trial, but if it is, or if you're aware of it, that seems that big impact on MRI.
Last week, I think a publication came out, single arm. So those not in the Georgia unload club on the end. So what this is there's we know Georgia balloon time. Put a balloon up in somebody coming in with a STEMI. Give yourself 90 minutes. There's some animal work going back a decade or two, thinking about the ischemia reperfusion injury and the damage we do when we open up the artery. There's a way to precondition. There's been many iterations of how to precondition, but to precondition the myocardium to set yourself up for less ischemia reperfusion injury and a lower scar burden. One way to do that is, in an animal models that showed a lower scar burden post-MI, is if you spend 30 minutes before you open up the artery, unloading the patient or the pig in the animal models with an impeller. And so you unload, you decrease myocardial oxygen consumption, the mitochondria of the myocytes are less primed toward that reactive oxygen species, ROS-mediated oxidative stress damage. And last week, they presented favorable appearing single-arm data that say that, in the DORTA unload trial, this may be a new viable sort of brand new world of STEMI care. I don't think we have the trial data, the randomized data yet, but I think it's a fascinating story, and we will see. Naveen Kapoor and our colleagues out of Detroit are helping to lead that study.
So one thing where we struggle with, what do you guys want to hear from us in the clinic? I am EP, but I run into heart rate patients all the time. When do you guys want to start hearing from us at the process? Early, late, when they're admitted to the hospital with SWAN,
Yeah. So the timing of intervention, the timing of a referral for heart failure and advanced heart failure care early is the right answer. So NYHA 3 persistent symptoms, certainly NYHA 4 symptoms. We can't just diurese and better. They're hospitalized for heart failure, and it wasn't just they stopped taking their meds. The disease process is progressing to the point where they're hospitalized in spite of the best care. If they've ever touched an inotrope, that's a patient they were on and they were in low output and they needed dobutamine assisted diuresis for 2 days. They're likely to have to go back into heart failure. So I think NYHA 4 and sort of 3B symptoms, inotropes, if they're having recurrent ICD shocks in your world, so to me that's heart failure. So unless they have a VT substrate which is deployed, which we'd also like to hear about if we're having trouble. But ICD shock is just it's a canary in a coal mine. And progressive end organ dysfunction. And then a little bit, I'm sensitive to age as well, because we do get into a box where somebody can be too old for these therapies. We don't strictly have a number, but with age comes frailty. So patients have heart failure, and we're kind of in this window where you're thinking about it. They're 67, right? Maybe we can meet them and get that referral out there, even if it's a little bit too early, because when we look at it, we do an evaluation, typically right heart cath and a cardiopulmonary exercise test, we'll see pathophysiology that these stoic older individuals are hiding, and we don't know until we go and look at the blood. And we can begin to offer therapies such as transplant and all of that. If we wait a few years, they may sort of time out and become too frail or develop other programs. So in general, broad strokes, earlier rather than later. Obviously, we can't see every single patient that has NYHA2 heart failure and is doing well on GPT, but when they've got progressive, that trajectory is progressing towards decline, hospitalized inotropes, I think it's a good fit to refer back.
So I specialize in chronic lung disease, and any considerations other than pumping them full of albuterol that you see like pulmonologists do that may not be overly helpful for heart failure?
I guess the opposite of albuterol is stopping carvedilol for some reason if they're truly in COPD or asthma exacerbation, that might be a modality, but I love my GDMT and I hate to see it come back for some reason. That's a really good question. So I think we struggle a lot sometimes in the opposite direction. We've got heart failure and we're trying to differentiate what of their symptoms is going to get better if I put an LVAD in. What of their symptoms get better with a transplant? Are they going to succeed with it? What degree of reduction in DLCO can we tolerate? And there's some literature around that. To me, when we've got concurrent heart and lung disease, trying to pave the path forward and figure out what to make the patient better, it's the CPET that comes back, the cardiopulmonary exercise test. I get a lot of information out of it. In terms of practice, I just want you to do what you do with the lungs. I want you to make the lungs better, because the better the lungs are, there's not really many contraindications across our therapies, except for that beta blocker space. That if you can make the lungs as good as they are, what we're left with is then more of the heart that I can really help to differentiate and figure out, is this cardiac disease driving this, whatever the symptoms they have. Thanks. Thank you. Did you also you had one more?
I just had a general one about the vulnerabilities of immunity. How many people do you have walking around outpatient wise in that kind of setting? I mean, who manages that, and how are you guys?
We have a lot, actually. So different reasons why we might use them in the outpatient setting. And so who manages it? We've got a team of docs and nurses that help manage it. We prescribe it. They come to clinic, more frequently than our patients who are on nanotropes. We've got a sort of system of care between the nurses and the docs that they're hospitalized frequently for infections and things in the PICC line, but we manage through it. Who do we use it in? So some patients, we are trying to get them towards an advanced therapy, LVAD, transplant. Maybe they have a high BMI, we need time. We're going to go put them on Ozempic and see if we can get them towards a transplant by getting their BMI down towards the 35 range we'd like to see. Or sometimes we've got patients who we're not certain are going to succeed with an LVAD, right? In a way, living with a PICC line and milrinone is a good test of being able to manage a line and stay away from infection, because we're going to give them an even harder line to manage that's on their abdomen rather than on their arm. And so if we need time to further assess the patient, get to know them, try to get them out of shock if we can. We've got a lot of patients that are sort of in this limbo here. Can't yet get them to LVAD or transplant. There's some safety concerns, comorbidities. And we need a bridge to one of those therapies. Now, transplant, obviously, we've got patients who are status 4, who are living at home on nanotropes. That's the maximal therapy that they're tolerating, and that's where they are on the list. They're not sick enough yet to progress to 3, 2, or 1 in the hospital. And then we have a sizable number, not a huge amount, but a sizable number of high nanotropes where they're beyond the stage where we can offer an LVAD or transplant, and they feel a lot better. It just doesn't last for that long. And there's an interest, I'd say, just incidentally, we studied oral inotropes in the 90s with a few trials. They led to increased mortality. We had a big meeting at the NHLBI in December last year trying to figure out, well, what can we do next? So in the 1990s, when we ran those trials, we didn't have GDMT. So one innovative idea that came out of that is, can we use oral inotropes coupled with GDMT, and does that actually enable somebody to tolerate GDMT, that we sort of counterbalance the worst survival with the GDMT mediated improved survival? And if we can get away from the PICC line, we'll be using these all over the place. There's a much broader indication. The challenge now is it's PICC line and IV inotropes, which is tough. So probably should pass off over here. Thanks, everybody.
Certainly, when you talk about which patients and then the timing, that's certainly 2 big questions. And thank you for your expertise. So, you guys, we got another treat here. I'm going to present Dr. Matthew Goodwin, and he's our second speaker for today. And he's received his undergrad at Indiana University, master at Indiana University. Did a general surgery residency, Toledo, Ohio University. completed surgical critical care fellowship at Henry Ford Hospital, Detroit, Michigan, and cardiothoracic surgery residency at Ohio State University, Columbus, Ohio. His clinical interests are local arterial coronary revascularization, valve repair, replacement, your procedures, certainly to our topic, durable mechanical circulatory support. He's going to talk a little bit about the minimally invasive robotic. So I'd like you guys to welcome Dr. Matthew Toots. Can you hear me okay? So I've been after you for a couple of years, almost 4 years, and I'm going to talk a little bit about surgery. Tom's will come back to follow, so I'm just going to show a bunch of surgical videos. What really drew me to the University of Utah was working with our physicians and trying to build programs, specialty surgical programs that aren't offered everywhere, and kind of reach out to communities like Carson to let you know what we have available that maybe is available in this area, and how we can help patients across the Mountain West. Next slide. Disclosures. Cardiac surgery is always very naturally invasive endeavor. Sternotomy is the general approach for most cardiac operations these days. There's really only one good way to get to the heart, and that's through the line. And most operations today are still done through the sternotomy. It carries a lot of recovery time and some potential complications with sternal infections, and difficulty healing. So we have less invasive options that we are able to do cardiac procedures through. We can do valve repair replacements through upper and lower hemisternotomies. We can do thoracotomies for the second or fourth intercostal in the right chest and do a number of procedures that way. These are good options for patients. They have to be the right patients to have these procedures done, but the healing's a little bit better. You haven't provided the entire sternum. If you avoid a sternotomy, the recovery is much different than if you had to do a sternotomy. The last couple of years of the year, we've really been working to develop a robotic cardiac program, and so this is sort of the next iteration of less invasive cardiac surgery. So we'll go through some of the procedures we're able to now do with the Da Vinci Xi robotic system, but most of the procedures these days are going to be mitral valve repair and replacement. We're able to do tricuspid valve procedures as well. We started a robotic mid-CAD or coronary program. We can do ASD closures. We have a number of arrhythmia procedures we can offer, less invasive options. And we're taking out some intracardiac tumors as well. So the valve program is currently probably our busiest robotic program that we're doing. We can do mitral valve repair and replacements. We're currently considering all patients for a robotic approach. That doesn't mean all patients should have a robotic approach. So I'll go through some of the selection criteria we use to decide who would be a potentially good robotic mitral patient. The goal is always the same for any robotic procedures. To do the same procedure we would do open at the same results. So we're looking for very high repair rates that are durable, safety is paramount, and for mitral valve and tricuspid valve repairs, we're looking to leave the operator with successful repairs. Next slide. So the preoperative evaluation is pretty similar to any preoperative cardiac evaluation with a couple caveats. So for a valve procedure, we'd like to have a TEE, do certain things we're looking for to see if we're going to be a good robotic patient or not, left and right heart caths. We really utilize CT scan a lot for preoperative robotic evaluation. We're looking at the aortic size. We have to be able to cross-clamp the aorta through the right chest. If they have an aneurysm or larger aorta, that can become more difficult. We pay close attention to the femoral and aortoiliac system.
all these patients for valves are going to go on peripheral cardiopulmonary bypass. We're going to do a cut down the left groin and get out the left femoral artery and vein. They need to be disease-free and not have a lot of iliac disease flow on bypass. There's studies with femoral bypass that the stroke risk is a little bit increased. And so if we have any occlusive disease, that's going to increase your stroke risk. We would offer that patient a robotic approach. We don't look for any inherent vascular anatomy that may impact the operation. Next slide. So this is sort of our workup. We look at the echo, we look at the CT, and we look at the patient. We didn't get good candidate. So through the robotic procedures, we're giving integrated cardioplegia. So if they have AI that's more than just mild, it's going to be difficult to detect that heart. And so that would be a patient who wouldn't offer a robotic procedure to. We currently can't get retrograde cardioplegia very well through robotic approach. So that's why we do have AI. Severe MAC is always troublesome, even in open procedures with that patient, less likely to offer a robotic procedure to. Same with any significant LV or RV dysfunction. Cardiac protection is key. And so ventricles that aren't working as well need a little bit extra attention. And so that would be the patient that would go through a sternotomy approach. And pulmonary hypertension is another CAT scan, like I mentioned, gives us information on the chest wall anatomy, the femoral vessels, any significant atherosclerosis we encounter. So that's sort of our general approach to patient selection. So we'll go to the video. But this is a 74-year-old veteran. He had no medications he was taking. He was very healthy, but had months of progressive dyspnea, was found to have severe MR. So he went through that kind of standard evaluation we just went through. Then you have to put it. Yeah. So these are 3D images and then 2D images of this mitral valve. So review speech and prolapse. Probably we have some cord rupture. We really are focusing as we get this program up and going on kind of single leaflet disease. Bileaflet disease is still more difficult to prepare. But he had kind of your classic P2 prolapse with severe MR, and eccentric jet from the interior. So we do the robotic mitral and tricuspid procedures through the right chest. We mark out our incisions, and so we're always prepared to do a sternotomy if we need to in the operating room. It's quite low, but it's 3 port sites in the right chest and a little bit larger working incision in the fourth intercostal space. It's about 4 or 5 centimeters in size, and then this picture is just getting the femoral vessels out to start with. So, like I mentioned, we'll go on bypass through the femoral cannulation and then get our ports in and dock the robot, and then we're able to do the procedure that way. Next slide. This is that fourth intercostal working port. But the visualization is great. When we open up the heart, we have full exposure to the mitral valve. It's a high definition, high resolution 3D camera that the robot comes with it. So we're able to basically park the camera right at the valve and get a really good valve inspection. So all the valve repairs start the same. We identify the pathology of the valve. We match it up with the echo we have in the operating room before we started the case, and we make sure what we see on the valve is kind of matching what we see on the echocardiogram, and then we plan out our repair. So we're able to do all the same repair techniques that we would do open. We can do leaflet resection and repairs. We can do neocords. We will support the valve with annual plastic bands and rings, and then we'll test the valve before closing the atrium, leading off bypass. Next slide. Should have been there. But we can do a lot of concomitant procedures at the same time. So this 74-year-old on his intraoperative TE actually had moderate to severe TR with a dilated tricuspid valve annulus. So once we did his mitral repair, we took the cross clamp off and reperfused his heart. We did the tricuspid valve repair with the heart beating through the right atrium. So concomitant procedures can include different types of MACE procedures, tricuspid procedures. We're not really doing concomitant coronary work because that's a little bit different. We'll go through that next. But there are some concomitant procedures here that will offer with the robot as well. Slide. So we are offering pretty limited robotic coronary revascularization procedures now. And we really are approaching this through a hard team approach like we do with advanced therapies and heart failure. And so we're really trying to identify patients who will benefit from what we call a robotic mid-cap, which is a minimally invasive coronary artery procedure, and patients that will benefit from a hybrid PCI and surgical revascularization procedure. And so these patients are being a little selective with it first as well, but they're looking for, mostly normal EFs or mildly reduced EFs. We have a little bit of a weight cutoff, just the logistics of getting into the chest and taking the hammer down and doing anastomosis. We're excluding people with previous cardiac or thoracic procedures with the infusions. And then the coronary anatomy and how calcified it is, and if it's intramyocardial or not, can affect some of our selection criteria. The robot-assisted CABGs we're doing off. We don't put these patients on bypass, but that's sort of our backup strategy always. Cardiac surgery is the bypass machine. So having good femoral arteries to go on bypass is important as well. Next slide. There's certain anatomical considerations for this procedure, but these are patients with osteoproximal LAD disease. Some patients have significant left main. We're going to start doing more through that from the left side of the coronary patients as well, where we can get a good lateral wall bypass strapped on with using a wide graft off of Lima. And we look at the distant targets to make sure they're going to be suitable to bypass. Next slide. So these are two of the patients we've done recently. One was a 53-year-old male that had a pretty large STEMI in a weekend in Las Vegas. His wife, he went to the cath lab in Vegas and found a left main occlusion. Ended up having a PCI down in Las Vegas. They stented the left main into a ramus. It was a large ramus and had a chronically occluded proximal LAD. So he was in acute heart failure during his hospitalization. He was quite sick. He was on the ventilator, kidney dysfunction. EF was about 20%. So he was able to recover. He was put on good guideline-directed medical therapy. Came to see us in clinic. So he went through the usual workup, still had viability. You could see the LAD filling through some collateral flow on the heart cath. And so he was offered a robotic cath. Patient we did just last week was a dialysis patient that had a pretty significant history of esophageal cancer, actually had an esophagectomy and neoadjuvant therapy. Part of his transplant workup was a left heart cath that revealed significant left proximal LAD disease. It was positive with IFR, IVUS concerning. So he was referred to us for the robotic cath as well. So yes, This surgery is done a little bit differently than the valve procedures. We go in through the right chest. And so we use 3 robotic ports, which are these little incisions here. And so the camera goes in the middle, then the robotic arms are flanking, and we're able to harvest the mammary with the robot. So we take the mammary down, we flip it, divide it, and then it's just laying right there for us to do the anastomosis. And to do that, we'll make a small incision, usually through the 4th intercostal space. We've already used the robot to open up the pericardium, and we identify the LAD, make sure it looks suitable, and then through this incision, we'll do beating parts, off the pump, leave that LAD anastomosis. And we're able to check flow through the graft in the operating room with some flow probes. So we make sure that there's no new mold abnormalities on the echo, there's good flow through the bypass graft, and then that's the procedure. So with the robotic valve and robotic CABG procedures, we're seeing shorter hospital stays. If you look at the collection of evidence on some of the robotic cardiac procedures, it's shown there's less blood transfusion, less pain, quicker recovery, shorter hospital stays. So I feel that this is going to be an important area for our patients and also the hospital as we gain more expertise and experience. High volume centers have shown that this approach is very cost effective for hospitals. And so another area we're able to focus on is arrhythmia surgery. We're able to do the robotic maze procedure. We'll go on pump and open up the left atrium and do the ablations that way. We're doing more conversion procedures. Conversion is a less invasive ablation, epicardial ablation system where we ablate the whole posterior wall of the left atrium. For patients with AFib, and we've been doing robotic and thoracoscopic replacement of the appendage during the same procedure. So we're trying to branch out some of our less invasive cardiac surgery options, particularly for arrhythmia as well. Just because I work closely with Dr. Dan here on the heart failure side, not a lot of options for less invasive surgery for heart failure, but there are some. And as Tom mentioned, we're doing a lot of temporary MCS for our heart failure patients, especially in the pre-transplant, closer to that bridge to Kansas City or first decision setting. And so LVAD's one surgery where we've been able to do some less invasive kind of bilateral thoracotomy or upper sternotomy approaches. It's been a little bit more difficult with the HeartMate 3 being the only pump available now. The HVAD pump was smaller. It was a little bit easier to get into the thoracotomy approach, but a couple HeartMate 3s have been able to do with bilateral thoracotomies and preserve the sternum for eventually transplants, kind of our thought process. I'm always trying to think of ways to allow patients on temporary MCS to rehab and walk around the ICU. We have a great ICU physical therapy team that wants to walk all of our active patients, which makes me nervous, but I'm trying to think of ways to prevent complication, put it up in the chest or up in the neck, where they can still walk around and rehab. Which I had a case we did in the last year with that. But as Tom mentioned, we use a lot of Protect for the right side combined with the surgical 5.5 impella. That's a good biventricular support system in heart failure that allows patients to continue with physical therapy. One pump we didn't show was something that surgical central mags, and I've been wanting to put those in left invasively. It's putting in the left side of central mag is pretty easy and even easier with the robot and not having to do a big thoracotomy or sternotomy, but kind of saving the chest that way. Next slide. This was a really great outcome, a great case we had. This was a 48-year-old female who had non-ischemic cardiomyopathy. She presented with acute heart failure. She was known to our team from our advanced heart failure team. She had a history of mediastinal radiation, lymphoma. She was a petite woman. She was 5'4", and she was in shock. So she was on dual electrodes. Her index was quite low. She had signs of worsening end-organ dysfunction, so her encephalopathy was getting worse. Her renal failure was getting worse, and so she was in that phase where we needed to do something a little bit more aggressive. And so we had a team approach. She had this imaging showing her axillary arteries were very small. Her platelet arteries were very small. Her chest had been radiated in the past, and so we knew that getting her a transplant was really the physical therapy side, getting her up and moving her. Some patients get put on alcohol and they're bed down with dental cannulation until they get it. Puts them at a real disadvantage and kind of behind the eight ball on the big operation. So this is a lady we decided to put in a 5-5 and surgically. So slide. We were able to go in through her second right intercostal space and get into the pericardium. There really weren't too many adhesions from her prior radiation. So the heart beating, we just put a partial clamp on the aorta and sewed an 8-millimeter graft on the aorta. This is a direct impella approach, which we do open a lot, but haven't done a lot without the chest hernia. So once the graft was sewn onto the aorta, we were able to tunnel it up to the right neck and use the insertion kit to put the impella 5-5. We got the impella 5-5 and it was this small incision in the right chest, and we were pretty sure eventually get transplant. So that was the immediate post-operative chest X-ray. She stayed on the impella for over 40 days, continued to get stronger with rehab and stronger. The kidneys improved, the stats improved, and she was working every day. About 8 days, I think it was 20 days to be exact. He got her heart off her, so we were able to transplant. It was sternotomy that hadn't really been violated before in prior procedures, and she did quite well. She did well. So it's trying to push the envelope and what we can offer patients that don't have some of the traditional options. Yes. So why are we trying to build this program? I think it provides more options for patients. In some cases, patients like these options. They, getting a sternotomy, going through cardiac operation is pretty anxiety provoking to most people. And some people may allow refuse to have a sternotomy. So we're seeing more patients interested in these options, and I think they're providing good options for patients in our region. We have equivalent surgical outcomes. Surgery, the outcomes this way. Less blood transfusions, decreased thermal complications, and blood recovery. I'm trying to decrease the hospital length of stays in hospital visits. So that's it. I wish the videos were.
Devices in place. So we will approach all patients for a robotic approach. A lot of the congenital patients may have had procedures before, which makes it a little bit more challenging if they've had prior cardiac operations. But every patient's given consideration. One area we're hoping to grow into is aortic valve procedures. That's an area of growth for a robotic approach. And so it's not great for the older patients with stenosis. The calcified valves can be a little bit more difficult, but the AI patients, it's really a good robotic operation because there's not a lot of calcium on the aortic valve. Usually the annulus is a little bit dilated, and that's one area in the next year we're hoping to kind of expand our robotic program. So any congenital patient considered as well.
Like the bypass, but the congenital bypass.
Yeah, exactly. Because those, there's not good TAVR data for some of the bicuspids with severity high that don't have a lot of calcium. So that's an area we're hoping to go into. Yes.
How do you do beating heart bypass? How do you keep the area still that, I'm assuming you're not sewing into a moving target.
Well, that's a good question. We have these tissue stabilizers. So the heart is moving, but we have this instrument that stabilizes the coronary. And so we are able to open the coronary in between the stabilizer. We try to keep the heart perfused. So we'll put in a small coronary shunt that allows blood to kind of go distally. And then we just sew the anastomosis. So it's a little bit of a moving target, but we try to stabilize it the best we can. Yes. It's funny you mentioned, because I was just thinking about that earlier today. It would be I don't think it would be that difficult to look down the barrel of the aortic valve, see the septum, and do the resection. Because almost with the camera, we're able to see angles that aren't always as visible with traditional, sternotomy. But we haven't done a myectomy patient yet, but I'm sure someone's done it. But I was just thinking about that earlier today. Thought it would be a procedure that could be possible. Because it's a lot to get a sternotomy to have, a centimeter of muscle cut out of your septum. So, yeah, that would be a tough case, because we try to identify those open patients that are going to have mitral issues post resection, and so that would be a challenge. I think that'd be a little challenging. I think that's.
We have dessert back there, so I sorry a little late for the beginning part. But you guys have any other questions or any comments? But thank you.
Thank you
for coming here and helping us and supporting us and furthering our. Yeah. So, Carmela, thank you so much. I don't think we could have done this without you, and so I appreciate it. She started this from year one, and she's been doing it every year, and so this is a great asset to the hospital and to education, to the relationship with University of Wisconsin. Thank you, Carla. Thank you. Right. So
Make sure to bring your CME like tonight.
yeah, that's right.
Yeah.
Before 11 o'clock, right?
Yeah, it's full for our Utah. And if you have nursing, just bring your knowledge to me and I'll look at certificate.
You don't mind checking.
Thank you.
It's great.